Thank you very much. I really appreciate being here. Last time I gave a talk at the London School, I was at the end of the DTM&H course. I think we just invented light microscopy at the time, but it's been a few years since I was last here. What I'm going to talk about today is a bit of the global response to HIV, thinking about how we might apply that to NCDs, the current evidence-based interventions for HIV, the challenges we have with the Cascade, and then particularly focusing in on an implementation science approach and how we might use what the HIV world is doing for NCDs. I would submit that it was really this chart that changed the response to the HIV epidemic. You know, up until the mid-90s, everyone died of AIDS. And then in the late 90s, when the rollout of antiretroviral therapy became available, people in the West were treated, and they survived, and they lived a long time. People in Africa continued to die at a high rate. And it was really this phenomenon that by the year 2000 was viewed by the world as being unsustainable and unacceptable, and we had to really change that. So this is the response that followed that chilling observation of mortality. With the advent of the UN General Assembly Special Session on AIDS, PEPFAR, the Global Fund, the world contributed a lot more money, going from globally about $1 billion in lower middle income countries in 2002 to nearly a 20-fold increase this year, about $20 billion of funding for lower middle income HIV prevention, care, and treatment. And along with that, the number of people on antiretroviral therapy went from a few 100,000 globally 10 years ago to now more than 10 million people on antiretroviral therapy. So when you identify a problem, make it very clear, the world can respond, can fund it appropriately, and you get these dramatic impacts. Not only are people being put on therapy, but this was reported in Journal of Infectious Diseases just in February, an analysis of people just in the country of South Africa that had started on antiretroviral therapy during the 2000s. Sten Vermund wrote this editorial comment talking about the massive benefits of ART in Africa. And this report, just looking at the folks that had started therapy in South Africa, nearly 22 million life years gained in these cohorts of people in South Africa. So a tremendously effective intervention that is indeed saving lives. So we have quite a constellation of HIV prevention activities. There's evidence base for all of these. I'll go through them very quickly, but we have very good evidence, often in randomized controlled trial, of all of these interventions that are used for prevention of HIV infection. And when you put them together, it can make for a very compelling HIV prevention story and interventions that can be funded with the confidence that actually you can yield prevention benefit from these. I'd submit, though, that it's really treatment as prevention that's changed the response to the epidemic. We had several years of failure of HIV prevention trials, and then over the last 6 years, some substantial successes in HIV prevention. The male circumcision study shown in the middle, about 60% protective efficacy when a man gets circumcised. Several studies of antiretroviral pre-exposure prophylaxis with efficacy rates from 44 up to 73%. But the item on the bottom of this, the 96% prevention benefit from putting people on early antiretroviral therapy has really changed the way we look at treatment and we look at prevention, because the HBTN 052 study demonstrated that actually treatment is prevention. And it used to be sort of a dyad between, do you put your money into treatment or do you put your money into prevention? And this study result came out in 2011, and Michelle Sidibe declared it a game changer, really mobilized the response that not only do we want to provide treatment to people that need it for their own benefit, but putting people on treatment renders them essentially non-infectious to others, and it's really mobilized the response for treating people to augment the prevention response. So this is a chart from WHO, and there was a meeting in Geneva a couple of months ago that talked about the evolving scenario of antiretroviral treatment. And because of the prevention benefit of antiretroviral therapy, the world is now moving towards a more universal recommendation for who should be on antiretroviral therapy. So again, just to walk through this a little bit, if I can use this as, so we now have about 10 million people on antiretroviral therapy. This is where we are now. WHO recommends that everyone with a CD4 count below 500 should be treated. Most countries aren't there yet. They're functioning somewhere back here. But if indeed everyone adopted the current recommendations, of the 33 million people living with HIV infection, 28 million would be eligible for antiretroviral therapy, and we're at about 10 million and moving upwards. WHO and the world are considering, should we simply move to a universal test and treat strategy where everyone that's HIV infected should be put on antiretroviral therapy? And that's an evolving discussion that's been driven by evidence. Randomized controlled trial data demonstrated that treating people is good for them and it's good for transmission dynamics. There are, however, an Achilles heel to the whole idea of diagnosing people, getting them into treatment, and getting them into care and putting them on treatment. And I'd like you to think about, when I show these things for HIV, think about how you could apply the paradigm for HIV diagnosis and treatment and how that might apply to NCDs. So this is the dismal situation we see in many countries of the world. Shown in blue are the number of people that are HIV negative, and in red shown those people that are HIV infected. The challenge is identifying people that are HIV positive, linking them to care, getting them into a care system, referring them to antiretroviral treatment programs, maintaining them on therapy with a good adherence, and then the goal is to have them virally suppressed. In the United States, where I live, 28% of Americans have suppressed viral load. The other 82%, or 28%, so the other 72% of Americans are walking around with virus, potential transmission sources to other individuals. So this cascade has driven a tremendous amount of analysis of how do we address the various steps of the cascade. To address the cascade, there's been a proliferation of interest in implementation science, and there was a meeting in Geneva where Thomas O'Denny and Elvin Gang put forth a working definition of implementation science to lead the effort to address the cascade problems with the HIV treatment cascade. So the working definition of implementation science is a multidisciplinary scientific field that seeks knowledge about the magnitude of and determinants of and strategies to close the gap between evidence and routine practice for health in real-world settings. How do you take research findings and make them real on the ground? I favor a more simple definition, which is really how do we move from what we know works to what we do on the ground. And as you know from working in developing countries, there's a huge gap from the best evidence to what we actually do on the ground. So Elvin Gang presented this at a WHO meeting a couple of months ago to try and categorize the various steps of the cascade. And how do we make sense of this? How do we take the global effort that's attempting to do prevention, care, and treatment, and how do we put it into digestible pieces for which people could design interventions to address this? So they looked at the various steps of the cascade, people that are tested, linked to care, having their disease staged, which often involves a CD4 count, maybe a viral load assay, retained in care, determined if you're eligible or not for antiretroviral therapy, and then if you're put on ART, have you retained an ART adherent to a complicated or a regimen that requires daily therapy, and then viral suppression, which is both good for your health and renders you essentially non-infectious to others. So they came up with several approaches to the kind of interventions that might be used in a healthcare system. And I think you could think about this for HIV, but a similar series of approaches applies for whether you're screening for hypertension, diabetes, cardiovascular disease, or cancers. So there's the delivery architecture. What structures of systems of healthcare delivery do we have? Are they decentralized, integrated, adjunctive services? How do you do creation of demand? For many of our HIV services, you have to create that demand for people that actually want to get into the services. The same would be for NCDs. Social support, how do you actually have a system of peers, community, families, or couples that encourage people, one, to deal that they may have a disease. Stigma is a major role in this. How do you overcome those with a series of social supports and then getting people into a system and retained in care? Counseling for individuals that are diagnosed and in care. And then how do you manage the system and what kind of technologies can be used? And a lot of exciting technologies, mobile technologies for people in antiretroviral therapy to encourage adherence to their programs. So this is the result of an analysis of more than 400 studies of different kinds of interventions to address the cascade of HIV prevention, care, and treatment. And I'll just walk through this a little bit. So they looked at these are all of the steps of the cascade. And these are those various approaches that can be used to address the various steps. And they did a heat map here of what proportion of studies address these. So the light colors are good. There have been 48% of the studies they actually looked at demand creation and testing. Those are 48% of those. And the red numbers are where there's been relatively little evidence. So these are studies that address the various stages. And as you can see, there's a relatively little amount of pre-antiretroviral retention. That is, individuals that are diagnosed as HIV positive, but they aren't yet eligible for antiretroviral therapy. Retaining those people in some kind of a care system so they eventually could be made, could have access to antiretroviral therapy is a major step. And you might think about this for any of our NCDs, that if you diagnose someone and you don't yet have an available therapy for them, how do you retain those people so they could be available when they're eligible for their therapies? So I worked with a colleague, Rebecca Dirks, at FHI 360, and we made this sort of comparative chart looking at the HIV Cascade and the NCD Cascade, and you can spend a bit of time looking at this. There are similar aspects of the prevention, diagnosis, enrollment into care, disease management, and palliative care. And I would submit that as we begin to roll out prevention care and treatment programs for NCDs in the world, this might be a useful framework to think about how we look at our current evidence base for what interventions are useful and create this kind of a schema to think about how do we screen for hypertension in African countries? How do we do the diagnosis? How do we get folks enrolled in care? What's the model for disease management, and how do we support people in the various palliative care issues? As you see in the NCD, there's raising awareness, early detection and screening, referral, early treatment, behavior change, counseling and linking with social support, behavior change, counseling, lifestyle change, treatment adherence, routine monitoring and self-management, and leading on to rehabilitation, pain management, and psychosocial support. So I think this framework could be useful, and then when you identify gaps in the knowledge base, use that to generate an implementation science agenda of issues that studies that could be designed to address those various steps. So in summary, I think we need a renewed commitment to addressing non-communicable diseases and thinking about what it was that motivated the world to increase therapy for HIV, or increase funding for HIV by 20-fold over a decade. Can we do a comparable thing for NCDs? The HIV response offers some examples for that. Having very good evidence-based interventions, which I think we have for NCDs, but making them explicitly clear to decision makers at the country level is going to be very important. Looking at the cascade of prevention, diagnosis, care, and treatment. With HIV, it's been very well spelled out in many countries. I hope this afternoon we'll hear about this with some of the other diseases. I suspect the cascade looks perhaps even worse for NCDs in terms of the proportion of people with a condition that are diagnosed, linked to care, and effectively on treatment. And I would submit again that implementation science can help identify ways to improve the cascade, leading to decreased morbidity and mortality, and improved quality of life for the individuals around the world with NCDs. So again, thank you very much for your attention. I'd like to thank many colleagues who've helped me with the presentation and submitted slides. So thanks very much.